So good evening, everyone. I think Sergey sent me a message that he has too bad connection. So I hope you can hear me well. Otherwise, give me a sign. I will try to speak not too quick for those who don't speak or don't understand English very well. So maybe I spend a few words to introduce me. So my name is Federica Zanca. I am a medical physicist. I am Italian and I live in Belgium. My career has been toggling between academic and industry. So I spent 10 years at university as professor in medical physics in radiology. And I spent other 10 years in few companies. My last company was General Electric, where I was director for an R&D team around dose tracking. So that's probably why Sergey has asked me to give this seminar. I'm very happy to be here. I hope you will enjoy what I'm going to tell you, and feel free to ask a question, possibly maybe at the end. I will try now to share my screen. Let me know if this is okay. So I hope you can see it. I can't see the interface anymore of the webinar application. Maybe I just check with interface. Tatiana, can you give me a sign that you would see the screen? Or anybody else that tell me that can see the slides? Okay, it looks like it's fine. So while I'm presenting, we don't see the screen. So now I will try to put it back again. I hope you will see it. So I will turn off the camera and turn on the screen. Okay, eventually that. Okay, I'm asking to Tatiana now if she can see the screen. And if so, then I will start. Just a few minutes of patience. I turn off my camera, so normally that should work. Yes, okay, that looks fine. Excellent. So we are going to start. So what are the learning objectives of this webinar? Well, first of all, I would like to try to explain you what is the impact of dose tracking tools on radiologists' daily practice. Then I would like to explain you how you can use it in your daily practice to optimize protocols and workflow. And third, I would like to report some examples of projects I managed relating to dose tracking system. I am a consultant currently, and I help hospitals to do this kind of project as well. The outline of my talk is explained here. Introduce you to dose tracking system. I will first explain you why you could need a dose tracking system, why it's important. Then I try to explain you which type of dose metrics and behind those you would be able to get, how you can get them, also which other tools are available in a dose tracking system on top of those. And at the end, I will try to tell you, okay, what does it take eventually to install such a system in a department? This will be the first part of my talk. In the second part of my talk, I would like to introduce you to some examples. These are research that I did with, of course, other partners. And I will try to focus on pediatric, and I will give you also an example of a quality story. And then I will go through the conclusions. Okay, so why it's important, or why dose tracking system? Well, there are three main reasons. The first one is compliance. As you might know, the European Union supports radiation protection through some legislations. And the last one, which is called the Basic Safety Standard, is the one which has been released in 2013 and has been implemented in the European countries by 2018. In this directive, there are regulation explains regarding the fact that each hospital should track and register those. Next to it, there is also, of course, the Joint Commission, which is a US body, which has also updated diagnostic imaging requirements in US for CT and fluoroscopy. You also have the ICRP, so the International Commission on Radioprotection, which has recently released a document which is called the ICRP 135. And in this document, they just redefined or re-explain the definition of diagnostic reference level. So those levels which are used or should be used in imaging for exposure. And third, you also might need a dose tracking, or at least a dose tracking system can be useful also for accreditation requirements. And here I'm talking about quality, like, for example, GCI accreditation. These are accreditation from external bodies in your hospital, which gives you a label, a quality label. And dose tracking system has been in the past very useful for, of course, accomplishing a part of the quality requirements of this Joint Commission auditing. The second aspect for which you might want to have a dual reason, a dose tracking system allows you to justify, for example, high dose. It allows you, as I will show you later with some examples, to optimize your protocols. It allows you to assess individual risk, like for children, pediatric patient, or any patient in general being exposed to ionizing radiation. And it also helps to create awareness around patient safety between the patient itself, but also among radiologists and technologists. And the third point, which is relevant when we talk about dose tracking system, is that it, if installed and used properly, and with properly I mean in a proactive way, it can bring a lot of outcomes, like it can improve, as I already said, the quality assurance of your department. It allows you, for example, to estimate cumulative patient dose. It can be useful for research. It can help you to define your own clinical dose reference levels, and more and more and more. So there is a gain in using this type of tools. So which type of dose metrics can you get from this dose tracking system? Well, when we talk about dose, you can have like direct dose measurements, like organ dose or effective dose, which is probably more familiar to you. The problem is that these measurements, direct measurements obtained with dosimeters, are more difficult to get. So often we rely on computational model for that one. Secondly, in this dose tracking system, but in general also as medical physicists, we use what we call surrogate of dose. And these are the CTDI vol, DLP, the size specific dose estimate, or other related to fluoroscopy, like cumulative exposure time, R-kerma, DAP, peak skin dose. These are machine related parameters which are not a direct measurements of dose as intended here, but they are a surrogate. So it's a way of measuring dose. They are easier to obtain, but they are more difficult than those to interpret if you have to discuss them in terms of radiation the treatment. So to describe the total harm by exposing a patient to radiation. So these are metrics which are collected in a dose tracking system, so both of them. And the next is, how do you get them? So get these dose metrics. Of course, you have three different ways. The first is that you connect to the modality, so to the machine, from your CT scanner, your X-ray system. You can get this information thanks to standards which are existing, like the DICOM standards for radiation dose structure report, the DICOM MPPS, which is less detailed than the radiation dose structure report, the IHE profile RAM. But you can also get it from third parties, like via the PACS or the RIS. However, there are still a lot of hospitals who have legacy equipment, old equipments, which do not have this standard. They are not yet compliant with this standard. And in this case, what do the company who sell dose tracking do? Well, or you can enter this information in the dose tracking system manually, which is not very recommended. You can also read the image headers, or you can go through OCR, so optical character recognition. And these are the ways that the companies use to be able to access those information, considering the first one the best and the standard and the most reliable, arriving to the manual approach, which is of course less reliable. I just want to make a note, and the note is that we are talking here about dose tracking system, but I would like to just share with you that this type of systems nowadays, they also collect contrast dose information. I'm not going to spend time on this, but just for you to know, the system are becoming more and more complete. So I have told you at a very high level why you need a dose tracking system, which type of dose metrics you have to collect, how you collect it. And now I'm giving you an example of a data sheet of a dose management system which lists all the tools that are available to assist you when you have a dose tracking system. So I'm not going through all of them, I'm just mentioning some of them. Typically, you have a list of performed exams by modality, the site, the device, the period. The system are vendor neutral, so it doesn't matter if you have a machine from GE, from Philips, from Siemens, they will be able to collect them all and from all modality. You are able also to track information related to nuclear medicine. You can, as I said already, contrast information. You can have automatic alerts based on, for example, some dose level. You can put some dose level in your system, and the dose tracking will alert you if a patient has a dose which is higher. You have working list and so on. I would like to focus on few of them because this could be more relevant for you. Specifically, I would like to spend few words on a tool which some of these systems have to give feedback on image quality, and also on the capability that they have to calculate effective dose for all imaging modality, as well as on the capability that they have to calculate radiation dose to the fetus for a pregnant woman. So I will give you some example of these three things. So this is an example of an interface to estimate image quality. In this case, this is a kind of pop-up image which is open when you click on a button on the PACS, and it is connected to a dose tracking system. Why do I want to show you this? Because often, and you will see it later in the example, when you let's say when you do collect doses and you want to optimize your protocols, you cannot optimize without looking at the image quality. So this is a tool that can be used, for example, to evaluate the image quality through radiologists registering themselves and clicking on the different parameters who can be changed. And these data are saved and can be analyzed such that you can follow up if your optimization is going in the right direction or not. And I do believe that this is a very important tool to have. Second point I told you is that these tools are able to give you effective dose, and the effective dose is estimated using correction factors which are coming from the ICLP 103, 60, and so on, depending on the modalities and the anatomical region. What happens in this case, I'll give you an example of one of these dose tracking system, which is called DoseWatch, but there are many other on the market which does the same. As you can see, you have a page where you have the conversion factor used to calculate the effective dose. These are taken, for example, for CT. You can have conversion factors in terms, in function of age, for example, pediatric patient, adults, and so on for the different anatomical region. And then when you go, for example, in the tablet, giving you a list of exam, the system is able to give you an effective dose for the exam that you have just performed. And it also gives you this information in the study detail of a specific exam. So this can be very useful. As I said, the third example I wanted to show of this dose tracking system is that can be very useful is how to estimate dose to the conceptus. So if you happen that you have to scan a woman which is pregnant, you might want, I'm not sure if in Russia it's compulsory, but for example in Europe, in many countries, compulsory to write a document where you state how much was the dose and what is the risk for the fetus. So in this case, this is an example of how such a dose tracking system can calculate the dose to the fetus. So there is an interface, and typically in this case is a method which is called Angel method, is based on a paper which has been published, you can read it here, in Radiology in 2008, and it uses parameters like the depth of the conceptus, which is this one, and the perimeter of the mother, which need to be measured by the radiologist on the PACS. Then you enter this information in the DoseWatch or dose tracking system interface, and the system will give you a value, like in this case 29.43. This method is based on Monte Carlo simulation. I'm not going into detail. I just want to explain you how you could do it and how the system can give it. This method has some limitation. It only uses average MIS and only 120 kV, which might not reflect the practice in all cases. That's why the dose tracking system implement other type of other method for estimating dose to the concept. This is based on Duke University methods, which has released 53 models of pregnant women, and these models are matched to the patient. In this case, this is not a pregnant woman, it's just an example, are matched with the patient based on the water equivalence diameter at the level of the abdomen, and it estimates the dose to the fetus taking into account Monte Carlo simulation again. But the difference with the previous method is that in this case it takes into account the tube curve modulation, is based on CTDI vol, and it can be used at different kV. It also gives you an error bar. So you can see here, it also gives you the dose for the body of the fetus and for the bone of the fetus. So this method is, let's say, more detailed than the previous one. Although they are both good, let's say that this one is more detailed. Then I would like to show you a few more capability of this dose tracking system. They allow you, in order to optimize your protocols or your department, radiology department, It allows you also to generate reports. So reports where there are information regarding how many examinations you have done, what is the average dose, and so on. It gives you a list of exam and patient with the highest dose. It can analyze doses by procedure, by BMI, again, contrast information data. It can also do comparison if you have like imaging per imaging device. Suppose you have 3 CT scanners at your department and you want to compare them in terms of exams performed, dose. There is a tool in the dose tracking system that allows you to do so. And of course, you can export all the information in Excel in order to do some statistic on that. But I would like to focus again on one topic, and which is organ dose estimates for pediatric patient. Again, in this case, the dose tracking system have different methods. So one method is based again on publication. So it's a Moore method, and the publication can be found here. It's a publication of 2014 in medical physics. It's based on measurements done with TLD, so with dosimeters, on a phantom, pediatric phantom, having different size. And based on this calculation, some conversion factor are estimated and used to be multiplied by the SSDE. The SSDE is just a rescaling of the CTDI vol based on the patient attenuation at the level of the region that you are looking. And this is just giving you an example of an anatomical region which has been scanned, and the software which recognizing the different regions like the pelvis, the abdomen, and the thorax, and you have different conversion factors per regions, which are used to eventually calculate all the organ doses. So you could be confused in the sense that I show you different method. Why is that? Because today there is no standard method to calculate organ dose to the conceptus, and until there is no standard from the NCRP, the APM, the ACR, there might be value in comparing different methods. So multiple methods can be supported, and they can be based on Monte Carlo, on pre-calculated table, on conversion factor, and the tools, this dose tracking, typically have a comprehensive vision which addresses adult, pediatric, and special cases like fetal dose or pigskin dose and nuclear medicine. So I think I'm arriving at the last part of the introduction, which is, okay, what does it take to install a dose tracking system at my department? Well, what you can see is that the first thing is, of course, you need to buy a dose tracking system. This is quite trivial. You can go on the market. There are several today, and based on the need of your department, you can purchase one. Once you have purchased it, you need to install it. Install it and start to collect data. Installation is not trivial because it requires servers, it requires interface with third parties like RIS, PACS, and so on. Once this is installed, you might want to have a physicist or somebody who checks the quality of the data. Is the dose tracking system giving you the truth? Are the data which are reported correct? Sometimes, because the integration between the machine and the dose tracking system is not trivial, maybe because you don't have access to the standard, as I explained you at the beginning for the integration, there might be errors. So it is important to spot them. The fourth aspect that you have to look at, maybe when you purchase also such a system, is that you have to look at the interface. The interface which will be used by the radiologist, by the technologist. Is it user-friendly? Is it intuitive? Is it what you expect? So it's also important to check that. The fifth component is the reporting part. So these tools generate monthly report, weekly report, which are configurable. But depending on the tools you're using, they might have some features and having other which are missing. So again, it's important to check what do you need in terms of reporting and how are you going to use it. And if all this is done, then you can push on the button play and start to implement this in your department. And are you done? Well, maybe for the first month yet, yes, but on the long term, probably not, because what you need to do is to make this sustainable. How are you going to make this tool a tool which is used daily in your practice, and not a tool which is installed, used the first month, and then forgotten? And for that, to summarize this part, I want to just stress once more that what you need is, of course, financial investment. You need a strong collaboration with IT. You need an engagement of a medical physics expert. You need an important engagement of the technologist, and also engagement for integration with the third parties. Only then you can go from what we call dose tracking to dose management, which is a different level of working. And what does it take to make this sustainable? Well, by experience, what we did in the past is that you need a project driver. You need somebody who is the sponsor. And this is a picture we took really, with customers. And you need a team which is engaged. With these people, you need to define a common vision. So why do you install dose tracking? What is the objective for the year and for the department? Once this is defined, you need to define process. Who is doing what? Who is responsible for which part? Only this will allow you to get a project which is running, and it's bringing you results and outcomes. So practically, as you can see, you need to build radiation safety committees. You need to define goals, responsibility, and procedure. You need to standardize your acquisition protocol of the machine. You need to have a risk management procedure in place. You need to invest in education and training for the people using the software. And you also need to communicate and marketing that also outside, to engage patients, to attain patients, and to show that your hospital is caring about radiation safety. Probably I will skip, because I would like to go now to the second part, as I want to leave some time for the questions. So in the second part, I will just give you some examples. And I will focus specifically on two, on pediatric and on a quality story. So the pediatric is a study I did with a team in Belgium, where I'm living. And it's a multi-center study. So what we did, in fact, this is Belgium, it's in Europe, between Germany, Luxembourg, and France. And in the north of Belgium, we did a consortium with few hospitals, and we started collecting data and for pediatric cranial CT procedure, specifically for dose and acquisition parameters. What did we do? Well, we collected data, this CT had data for pediatric patients for 1 year in 3 different hospitals. We had 5 scanners from different companies, all using iterative reconstruction. We had a dose tracking system installed, and we collected CT-DI vol and dose length product, as well as scan length and amount of retakes. We stratified the data based on the pediatric patient age, and we also look at the clinical indication. And we also check if sometimes adult protocols were erroneously used for children. And now we go straight to the result. So the 3 hospitals participating to the study were a large city hospital, university hospital, and a small regional hospital. And what you can observe is that if this is the dose level, the DRL of Belgium for CT Ed pediatric, you can see that each hospital is doing very well, actually below the dose level. However, you can also see that there are large difference in dose between this hospital and this, which are much lower, showing that there is still room for optimization here. This one has low doses because it's the only one implementing age-based protocol. That's why it shows the lowest dose. And you can see that there are outliers, and this is because adult protocols were used for pediatric patients. So showing the scan length, this is an interesting slide, per hospital, you can see that the site C, which is the one who had the lowest dose, had, strangely enough, the largest scan length. So they were scanning too much in length. Why was that? Because they just had an upgrade of their system in which an automatic anatomical region selection was implemented, so the technologies were not adapting the window for the scanning area anymore, relying on the machine. So the study was very useful to show that the technology had to go back to adapt the window again to the scanned area to be able to drop to a lower scan length. The second example I want to show you is something that we presented at RSNA in 2017. It's again a multi-center study, this time in Switzerland. This is a courtesy, some slides of Dr. Brack, which is from Trazer. So in this case, we use the dose tracking system to build what we call the dose excellence program based on clinical indication, body mass index, and diagnostic image quality. So in fact, what was I will skip the background, I think. What was the purpose of the study? It was to set up a radiation dose optimization and education program at the level of the group, which is private group. So the group encompasses 7 centers and 7 scanners from 3 different manufacturers. And the second objective was to implement a dose culture among the technologies, which were 22, and among the radiologists, which were 22, and the radiologists, which were 40. So this is an example. Well, this is actually the region of Switzerland in which we implemented the project. You can see that we had to do also a lot of telemedicine, and they were quite spread. So the first step we did for building this dose excellence program is expressed to this workflow diagram. Going back to what I told you before, the first thing when you want to do this is to define a vision. In that case, we did it with the stakeholder, which were industry, the dose management company, medical physics expert. You define a steering committee of people who are responsible for the project, and for each subgroup, you define a team leader. Here you can see that to define the vision, so this part, we organized a meeting in which we had all the 7 centers and all the 7 local dose team, and we had a 2-day workshop where we defined the goal, the strategy, and the methodology. And specifically the strategy was to harmonize the protocol across the different sites, which means that if inside site A they had a CT scanner using, I don't know, a head pediatric protocol with certain parameters, this had to be harmonized to site B, for example, until everyone was harmonized in terms of protocols. And the second step was optimize them. So once they were the same overall, the next step was to optimize them. So the second step was that in each site where the dose tracking system was installed, the technologists had to justify if there were high doses occurring. And the objective was to reach 100% justification of high doses. There were local dose teams built, and this had the objective of ensuring local training for the technologists, verify the dose tracking, verify the dose excess investigation, and ensure that any high doses was justified, such that also awareness was increased. So this is just an example in the direction of the harmonization phase. So how did we do it? As the protocol name on scanner A might be different from the protocol name on scanner B in another site, we used the RADLEX nomenclature. This is a standard nomenclature per clinical indication. So we did a mapping between the protocols and the RADLEX. So protocol A on site A could have been called chest standard, and it was mapped to the RADLEX nomenclature for the chest. and inside B could have another name, but still mapped to the same Radlex nomenclature, so that we were able to analyze our data based on this code. We also designed clinical indication-based protocols such that from the protocol name, we knew which clinical indication it was meant for. And we also stratified them by BMI. So we had, for the same clinical indication, one for a protocol for BMI less than 25 and one for BMI larger than 25. And the dose was such that we tried to match the DRL of the country for that protocols. So we go indeed to the phase of the harmonization or standardization, where, as I told you, we have indication and BMI-based protocol map. And how did we do this? We just contacted a CT field engineer of the companies, so Toshiba, Philips, GE, and so on, which helped us to do this configuration. Second step, as I told you, once we harmonized all the protocol, was to optimize them. How did we approach them? Well, we started with a dose reduction phase of 12% of the mass, step by step. And using the tool that I showed you before, integrated with the PACS, we evaluated the image quality by radiology. And every time that there were negative votes for at least 2 radiologists, this was revised and brought back to the 12% higher. And here you can just see again an explanation, a schematic explanation of the optimization phase with the different steps. The 3 radiologists, the radiologist evaluating the case of 3 negative votes, and eventually they look back to increase the dose again. So just to give you an example, this is an example of a known hypodense focal liver lesion in segment 8. And you see this is before optimization and after optimization. So you can clearly see that the image quality here is worse. There is no doubt about it, but it was enough for the clinical indication. So that allowed us to go towards a very good result in which we were able to reduce dose by about 26%, as I mentioned here. It allowed us to standardize practice across 7 hospitals, and it allows us to register those systematically, and this through all the steps that I already explained. So this brings me slowly towards my conclusions, and what I would like you to take home is that a dose tracking system can change the practice of radiologists at different level. It can change it in terms of clinical excellence, helping hospital to strive to clinical excellence, because it allows you to standardize protocol and optimize it, inclusive image quality. It allows you to do risk management. I didn't show you anything here simply because of lack of time, but believe me, you can do risk management. And it also allows, and this is very important, to engage your team and to raise performance also of the staff. A second aspect in which a dose tracking system can bring you advantage is that it also helps you to to bring more patient satisfaction. Patient satisfaction because you are able to tailor the protocols based to the patient, because by raising awareness, you are also your technologies are more able to communicate with the patient, and it allows you, why not, if you do a good marketing, also to retain a patient. And if you also know the Eurosafe imaging campaign, which is a campaign launched by the European Society of Radiologists, you know that a lot of hospitals get what they call the wall of stars, so 5 stars for being hospital that focus on radiation protection and optimize their practices. So if you're able to show this to your customers or to your patients, this is definitely a nice thing to do. It might have some impact also in terms of economical value. Why? Because it allows you, for example, to assess the value of new technologies. You can assess the value of a new iterative reconstruction, of a new acquisition method. it allows you to optimize equipment based on clinical needs. Maybe it can also allow you to look at the tube life assessment by checking, for example, the total mass given by all the exams that you have been performing. And finally, going to my last slides, I think it's very important to benchmark. So such a software can allow you to benchmark yourself against other leader in radiology like you, and improve by comparing yourself, by learning from the others. And that's, I think, very useful, and it allows you to go one step further and improve yourself always. So with this, I would like to conclude. And I would like to invite you to our EOSOMI annual meeting, which is a medical imaging informatics in AI, clinical application, and more, which will be held in October in Spain. So you are very much welcome to join us for that. And I'm very happy to take questions if there is any now. Okay, so I see that there is one question. Are there any diagnostic annual dose limit? And what would be the role of those tracking systems for tracking of such dose from different exams performed in different institutions? This is from Anastasia Kusova. So thank you, Anastasia, for the question. So there are no diagnostic limit. There are no diagnostic limit. However, what exists in each country are diagnostic reference level. These are those levels which are recommendation. So it means that they say, for example, that if you have an abdomen CT and you collect all the dose of your department and you take the median, so the P75, this value should ideally not be higher than this dose level. But I recall this is not a dose limit, is something which is meant for optimization. So it happens like this. For example, suppose I take as an example Russia. How do they would build dose reference level? They would take the dose from each hospital for each exam, or at least for the most relevant anatomical region, and pay attention, not clinical indication, anatomical region, chest, thorax, abdomen, head, and they put all the doses of all the hospital together. They build a Gaussian curve, and in this curve they take the P75. And they say this is what 75% of the patient in Russia get for this exam. So you too, from this hospital, should be ill. Now, what happens if one patient has a dose which is higher than that? As it is not a limit, nothing happened. But you should go and check if this was justified. Was it a high dose because the patient was very thick, very big, so it needed more dose to have a good image quality? Or was it a very thin lady, and this was just that the protocol was not optimized and the dose was indeed too high? In that case, you have to report it. So the answer is no, there are no dose limits. There are DRLs which are meant to help you optimize your system and your practice, depending on the clinical indication, the anatomical region, and the patient. So I hope I answered your question. And maybe to continue on that, until maybe another question comes, is that every country has its own dose reference levels, and typically they are reviewed. They were reviewed every 3-5 years, but now there is a new European directive, the one I mentioned at the beginning, which requires that European country revise these dose reference levels on a yearly basis. And there is also the tendency to go more towards dose reference levels based on clinical indication rather than anatomical region. Okay, so if there are no other questions, then I would just maybe thank you, all of you, for your time. I would be very happy to make myself available eventually if you have other questions later on. You can always reach me through my email. I think it is mentioned on the presentation. And good luck with your dose tracking system and your dose optimization at your hospital. Thank you very much for your attendance.